Thank you for your invitation, All Indian Ophthalmology Society. I'm proud to stay here. Thank you, Kamal Kapoor, for your invitation also. Well, today I will talk about IPCL for myopia and presbyopia. My name is Germán Bianchi. I'm from Argentina, Buenos Aires. I don't have any financial interest to disclose. Well, Dr. Kamal Kapoor talked about the main characteristics of the IPCL. We have 4 models now: spheric, toric, diffractive, spheric, and diffractive toric. And we used to correct myopia, hyperopia, astigmatism, and presbyopia, but I prefer myopia, astigmatism, and presbyopia. And it's an hydrophilic polymer with different size between 11 to 14, with different optical diameter, and could be customized also. This has 2 holes in the upper part of the optic, 1 in the middle, and is conic, and this conic reduces the scattering of the light. And another characteristic is the diffractive characteristic of the lens is diffractive and refractive with trifocal optical design, with different rings between 5 to 9 rings, depending on the addition of the for near vision, and is between 1.5 to 4 dioptria of addition. And it's important the pre-op study, the indication and the contraindication study very well the endothelial cell density, corneal topography, IOP, white-to-white, angle, and also the sulcus. And the exclusion criteria is like Dr. Kamal Kapoor talked before, and inclusion criteria is myopia more than -6, or thin corneas with myopia when you can't do the refractive surgery with laser. And for me now, patients with myopia and presbyopia is one indication also, and I am starting with emmetropia and presbyopia now. And more studies is very important study. All that you can want to study ocular motility, because sometimes it's important. Some patients have double vision after surgery. In this case with lens, it's important to study that also. And the pupil diameter. Actually, I evaluate the pupil diameter in different light conditions before surgery also. Like Dr. Kamal Kapoor, it's important to study this sulcus, because you need to know if this patient has some cyst in the sulcus. Sometimes have one, sometimes in this patient have in 360 degrees, and it's important to know this anatomy before surgery, and also the angle. And after surgery, we need to know the efficacy of this lens, the visual acuity refraction. And I made some satisfaction questionnaire to the patient. And the safety, the IOP, specular microscopy, pentacam, UVM, OCT, control always in the post-op. How to perform surgery? Well, my surgical technique is like that. I make the first incision with the V-lance and introduce the irrigation cannula inside of the chamber. And after that, I do the main incision with 2.8 millimeter knife, and I inject the lens inside of the anterior chamber. I prepare the lens always before I start with the surgery, and I put to the end of the cartridge to be safe that the lens is in the correct position. And this is safe surgery. I made this kind of surgeries from many years ago, and also with ICL. But you can use OBD, and it's a safe surgery with OBD also. I want to show you my experience with IPCL, the model B2. I present this, and you can find in PubMed the initial result from model post-op, new model of posterior chamber implanted phakic contact lenses. And I'm studying, it was an prospective case series of 100 consecutive IPCL surgery began in 2017. I am studying many things in that, in the endothelial cell density, the CCT, and it was without any statistical difference between before and after surgery until 6 months. The vault was stable after surgery also, and the IOP, I don't find any peak after surgery. I don't find any cataract on this patient also. And the refractive result was very good, 52% between minus 0.5 to plus 0.5. And more study, another study that I made is the diffractive facet posterior chamber lens is the IPCL for presbyopia. I present this in the Czech and Slovak ophthalmology journal, and you can find also in PubMed. Patients, presbyopia indication, patient with myopia or astigmatism within 38 to 55 year old without astigmatism. If the patient have more than one diopter of astigmatism, I prefer the toric IPCL. And the patient who want independence of glasses, I made a refraction in the pre-op, taking into account the best corrected subjective far side. And I evaluate the near side, not just by now. I evaluate for the next 5, 10, 20 years, depending on the age of the patient. For a younger patient, until 45 or a little bit more, 48, I prefer the blend, different addition between the dominant eye and non-dominant eye. I put in a dominant eye the most addition that the patient tolerates, and in the non-dominant eye a little bit more, 0.5 or 1 diopter if the patient tolerates that situation. If that situation is not tolerated, I put the same addition in both eyes, but the most that the patient tolerates. And when the patient has more than 10, minus 10 diopter, I choose 3 or 3.5. You can see here the nomogram. I take into account not just the age of the patient, I take into account the dominant eye and non-dominant eye in the option A. And also I take into account the myopia. And if the option B is with the both eyes with the same addition. This is a prospective non-randomized case series study that I present with 54 myopic eyes. And this was the inclusion criteria, and I studied endothelial density also, the corneal central thickness. It was stable without any statistical significant difference. The wall was stable after 1 year of follow-up. Cataracts were not developed in any of these patients. The IP, I don't have any peak after surgery, 1 day, 7 days, 1 month, 12 months. And I studied also this focus curve, the binocular focus curve, and I find very good near, intermediate, and far side. And this is the first lens, trifocal lens, that work together with the residual of accommodation of the crystalline lens, depending on the age of the patient. And these patients don't have halos. Another study that I present this year is the measure with different light condition, 2 years of follow-up with the scotopic and photopic condition were evaluated. You can see here how the bolt is moved. And you can see here how the bolt is moving. And when the light intensity changes,
Bianchi, we can't see your video. We can't see your video is frozen. Yeah, now we can see it. Yes.
Now you can see the video.
Yes, now we can see. Yes.
Okay, how the bolt is moving, and we found that it's lower than 100 microns with the light condition that we proposed in this study. And it's very important how the lens changed the position. This is another indication for me now, correction in metropia with the phakic IOL. And this man 50-year-old with very good and corrected distant visual acuity without any ocular problem, no cataract. And the patient said, what can I do for me, doctor? This is the refraction. And I choose to put this kind of lens, the IPCL, with plus 0.5, and I choose for the dominant eye plus 2, and for the non-dominant eye plus 3, and I have a very good result.
Bueno, acá estamos con Luis, que se operó con
You can read the subtitles there.
para ojos se meten en la noche, te molestan las luces, las halos. ¿Es algo de eso?
He was 20/20 before surgery, and after surgery a little bit more. 2015, it's very good vision. He can read this kind of letter, and also for the near vision. Checker 1. He's very happy. I start with this kind of indication. I feel very confident with that. And another important thing for me is that a reversible surgery is easy to take out. This is the maneuver that I use. Put the cannula.
Dr. Bainchi, we can't actually, the video is not very clear at all. There is, the resolution of video is not very clear. Maybe there is some problem in the internet or the resolution of the video.
Problem with internet.
Now you can see or no?
Very, very vaguely, very unclear video.
Wow. Well, sorry. Maybe it's the internet connection. I put the cannula. You don't know if you can see this or no.
Yes, yes, but very unclear.
Very unclear. Oh, sorry. Okay.
It's coming all the way from Argentina. It's a long way, so it's difficult.
It's so far
away.
The end of the world.
Many computers are crossing before the video reaches us.
Yeah.
Yes. Okay. Well, this is the way that I take out the lens. Sometimes we need to change the lens, and this is the way that I do, because sometimes we have a small bolt, or in this case, I have a little rotation in the toric lens. In the same way, I put OVD behind of the IPCL, and I put in the anterior chamber, and after that, with the same cannula of the OVD, I put in the hole of the optic. I take out the lens with 1 or 2 McPherson, and after that, I inject the lens. It's unclear the video. I'm sorry about that. Well, this is the final conclusion. The indications are growing also for this kind of patient, presbyopic and emetropic, no cataract or complication after 4 years follow-up. In the future, we need some more studies. Well, thanks a lot for your invitation.